Good afternoon, ladies and gentlemen. Welcome to this Gimme 15 Minutes education program for medical professionals. My name is Jennifer Searfoss, and I am the CEO of the Searfoss Consulting Group. This presentation is covering what you need to know about sequestration, MPPR therapy cuts, and TCM billing. This is a live session being recorded on March 12, 2013, and will be available for free through iTunes as a podcast or as a video archive with handouts on jensearfoss.com. One quick legal note. None of the information contained in this presentation should be construed as legal advice. I encourage you to contact counsel if you have any questions regarding state or federal law that apply to the concepts covered in this session. At the end of the presentation, I will cover your questions. Please submit any questions that you have using the questions box that is located on the screen for live participants. With that, let's go ahead and get started. We have a lot to cover in this very brief presentation. So let's start off with what we're going to cover today. And so that is actually sequestration. We're going to get into that and how this will affect your Medicare claims and patient responsibility. We'll get into whether or not this will affect any of your private insurer contracts, specifically if they are on current year contracts. We'll get into the multiple procedure reduction and how that's going to apply to therapy services rendered on or after April 1. And then we'll get into TCM very quickly. So let's start off with sequestration. Sequestration, again, is a great term that came up in actually the Budget Control Act of 2001. And it stipulated that if Congress couldn't come to a compromise, if both the House and Senate couldn't come to an agreement on how they were going to cut federal spending, that there was going to be very archaic across-the-board cuts starting January 1, 2013. So if you remember, again, this is a little bit of history, there was a super committee that met in Congress, both members of the House, the Senate, and the House got together, but they were not able to reduce spending by $1.2 trillion over 10 years. And so that failed reconciliation then led to, again, this cut coming into effect January 1. And again, sequestration right now was capped for Medicare only at 2% for Medicare provider payments. There was across-the-board cuts to the administrative services, which will be going into effect over the next several months. But again, the 2% cut to Medicare provider payments was $11 billion just in 2013. So that was delayed in the American Taxpayer Relief Act of 2012, and it was delayed for 2 months. And so it is kind of interesting, instead of cuts going into effect March 1st, instead for provider payments, they go into effect April 1, 2013. So some quick clarifications. This does not apply to the doc fix. This is also known as the sustainable growth rate. There was a 26.5% cut that was mitigated by the end of the year package, which also delayed the sequestration cuts. It doesn't change the actual rates that are being paid. So the way to think of that is CMS is not reissuing the fee-for-service file. Instead, they actually already sent out the April 1 file for carriers. Instead, these adjustments are going to apply after the claims are processed, and I'll give you some examples here. So the way to think of it, too, is that because this is not affecting the actual payment numbers, the RVUs that go into Medicare reimbursement, this should not affect your private insurance contracts. I do have a number of emails out to the private insurance companies that have what they call current year contracts. These would be private insurance contracts that are paid on a current percentage of the 2013 Medicare rates. Right now, everything I understand is that it is not going to affect those because the actual fee-for-service file is not being modified. But again, it's something definitely for you to reach out to any of your payers if you do have a current year contract. That also does apply to Part A and Part B payments. It does not apply right now to Part C and Part D. There may be further clarifications regarding the Part D, which is the drug coverage aspect, but at this time, this is not applying to Part C and Part D. Part C payments, if they are effective, and again, the cuts will directly affect Medicare Advantage contracts that are being paid in the 2014, so the upcoming years, not current contracts, but new contracts. Again, those would be going to the actual private insurance companies and not applying to the payments for providers. So let me give you some examples of what this actually means. So there was I won't call it a transmittal, it was actually an email that came out on March 8th, 2013. And in that email, Medicare, so the Centers for Medicare and Medicaid Services specifically said, and I have a quote here for you, so that it's going to apply, this cut is going to apply for dates of service with a day or date of discharge on or after April 1. And it's going to be a 2% reduction in the Medicare payment. For DME, prosthetics, orthotics, or supplies, it's going to apply for any date of service that's on or after April 1 or a start date of rental or a multi-day supply. But again, April 1 is the start date for when that would apply for any reductions. So let me get into an example for you. The first example I have is where, again, I'm using here where Medicare allowable is always $100 because the math there is very easy. And again, using the quote from the email that CMS sent out is that the claim adjustments shall be applied after determining coinsurance. So the patient actually is going to bear a bigger responsibility, and the cut does not apply to the coinsurance. So again, looking at our first example, Medicare allowable would be $100. On traditional Medicare, this would mean that it's an 80-20 split. The patient coinsurance, therefore, would be $20. But they have a full unmet deductible, and the deductible for 2013 is $147. So in that instance, the 2% cut doesn't apply at all, and the provider would be paid $100 directly from the patient. In the second example I have for you, again, the Medicare allowable is $100, and so let's go back to that 80-20 split. In this instance, let's say that there is no unmet deductible. They fully paid the $147 for services that were rendered, let's say, in January. And so in this instance, there's a 2% adjustment that is applied to the amount that Medicare pays. So again, the coinsurance in this instance from the patient would be $20, and therefore the patient responsibility is $20. And Medicare is going to pay $80 minus $1.60, which is at 2% of 80% or $80, and Medicare therefore pays $78.40. My third example for you is where you have a partially unmet deductible. So again, let's say here that Medicare allowable is $100. The patient coinsurance therefore is $20. They have a $50 unmet deductible, so $70 is coming from the patient. That leaves $30 left over for Medicare. So you take 2% of the $30, and that comes up with 60 cents. So that's what they wouldn't pay there. So they pay $29.40. And again, looking at another example, let's say that there's secondary insurance. So again, $100 allowable, patient coinsurance is $20. Secondary insurance pays $50. Therefore, there's $30 left over. And again, the math works out the same as the last example. So a couple different examples of where this applies. It's really only going to apply, again, to what Medicare pays. Therefore, the patient, or the way to think of it is we, the taxpayer, are bearing a greater responsibility than just Medicare. So something to keep in mind here, this is going to be a little different on your math than you've done before, and it really does emphasize the reason that you may, for complex cases, want to wait for your explanation of benefits. So again, if you have any questions, go ahead and put those into the question box, the chat box, and I can answer those at the end of the session. But that gives you a brief overview of what's going to happen with sequestration. Again, it's for all services under Medicare Part B. It also will apply to Part A inpatient claims, but again, those are for more complex DRGs. And I'm a humble lawyer, so we're not going to get into that math. So let's move on to the MPPR and therapy. Many of you may be familiar with the MPPR. It's a long-standing CMS policy. Again, it stands for the Multiple Procedure Payment Reduction. And again, this has been around for quite some time, where CMS has had the policy that subsequent services should be reduced by 25%. There's some flexibility that's been out there, and again, for therapy services in 2010, Congress got involved in the Physician Payment and Therapy Relief Act. For in-office settings, they actually set the rate, instead of being 25%, they reduced it to 20%. In institutional settings, it's always been 25% for subsequent therapy services performed on the same patient on the same day. The American Taxpayer Relief Act came in and actually increased that reduction to a 50% reduction. And so again, that's a significant cut to therapy services. This is going to garner out of the, if you will, the physician or institutional pocket $1.8 billion over 10 years. as Congress was looking for money to pay for this latest American Taxpayer Relief Act. So a transmittal came out in February. It's transmittal 1194, and if you're looking for the Medicare Matters, which is now called MLN, the MM8206 is the one to look for. What it clarifies, again, is that this cut is only to the practice expense. It's to the PE payment only, and therefore the work and malpractice is not going to be reduced. I have an example here for you. I will note if you go into the current Medicare Matters article, their math didn't add up correctly. I was very proud of myself for catching that, but I'll give you the example with the correct math worked out. So this cut does only apply to quote-unquote always therapy services. I'll show you where you can find those. For those of you who are big geeks like me and you happen to have the RVU file from Medicare, it's the one that the column you need to look for is a multiple procedure file, and this is again for the physician side, and it's value 5. For institutional claims, you're going to look at the therapy abstract file, and again, it's value 5, which is for therapy services. Again, there's a new file that just came out for April 1. I tried to download it, but for some reason it's actually not populating correctly, so I'll wait for the cleaner Excel file to come out. But we're looking at 31EE is the file that they have, the column they have for where the calculations will happen. So just to give you an example of what you're looking for, I posted here, this is the 2013 file that came out with the original American Taxpayer Act revisions. What I've highlighted here for you is over in the multiple procedures column, you can see that there's some 5s here. So this is for OT evaluation and reevaluation. There's athletic training, for example, and that evaluation has a 9, so that wouldn't apply. But your medical traction therapy would apply, your contrast bath therapy. So any of the therapy services that have an indicator of 5, those are where you're going to have the reduction. So let's quickly check out the math. Again, this is the example that is from the Medicare Matters article. However, again, just to highlight for you, the math in therapy 1B actually doesn't work out. But the example that they provide for you was a therapy where there was 2 units that were provided of one service and then a second therapy procedure that was performed. So again, looking at the math, the first therapy services with the 2 units was $18, and the second therapy service was $20. The first therapy service, again, they're going to start with the one that has the highest practice expense. In this instance, it would be both the therapy 1A and B. So that's $10. They're going to start with that one. They're going to pay the first one in full. And then the second therapy services and anything subsequent for that same patient on the same day, they're going to look at the practice expense and they're going to reduce it. So the adjustment here is to the therapy 1B practice expense of $10 and the therapy service of $8. So again, you can reference this again in the Medicare Matters article. But the way that the adjustment works out, if the practice expense for therapy service 1B is $10, that's reduced by 50%. So that means it's a $5 reduction. On the second therapy service, the practice expense is $8. It's reduced by 50%. And again, the reduction there is $4. So the original payment under their scenario should be, and this is where the math doesn't work out, $56. And the adjusted payment is $9 less, where it's going to be $47 for these 3 services. So again, just to point out, this is a significant reduction in therapy services. This applies to in-office services that would be performed under the Stark in-office ancillary exception where they are incident to a physician. This applies to therapy services that are performed in a PT-owned location. This applies to those types of therapy services that are paid under Part B that are performed in institutional settings. So this is a significant cut that's happening as of April 1. So moving on, our next item on the agenda is on TCM Billing. TCM Billing is getting into a very interesting new service that's out there, and I'm going to rush through this as we're right at 15 minutes. Again, if you have any questions, I'm going to briefly get to those here. First point here on the TCM is there are 2 services that are out there. They are covered as of January 1. There were a number of questions related to the 99495 and the 99496 transition care management codes. Again, these are the 2 new CPT codes as of January 1. And what happened was that a new frequently asked question document came out February 28th, and I'm very proud to say that one of my questions is in there. Not that we like the answer, but it's at least in there. So just to give you some ideas of what's in the frequently asked questions document that is available on the CMS website. A couple things here, dates of service. You need to bill those services on the 30th day after the discharge. There is a 30-day period as part of the TCM for providing services, and you bill it on the 30th day, and that is the actual day that is going to be on the claim. Then the place of service is the location where the actual face-to-face visit that's required as part of the codes is located. So again, if it's in the office, that's the office setting. If it's in the home because it was a home health care visit, then it would be in the home. Readmission, what happens if the patient is readmitted? That is actually just going to be, it depends on the way that the situation is. If it's a short readmission and all the services in the code are met, then you would bill it at the 30th day, even though there was a second readmission. What happens if the patient dies? This is the one that I was not very happy about. In this instance, if it's within the 30-day period, then the practice would need to bill an E&M service. They are not eligible for the TCM services. And the last one is what happens when there's multiple claims, multiple providers believe that they're providing this service. It's the first in line, first in time. So only one provider is going to be paid, which means that the first claim received is going to be the one that is paid. So with that, I wanted to go ahead and move into questions. I know this is really quick. So one of the questions that came up is that the 2% isn't applied to the conversion factor. And yes, that is correct. The 2% reduction from sequestration is not being applied to the conversion factor, to the relative value units for work, practice, expense, or malpractice, or to the GPCIs. Instead, actually, it's going to be an adjustment that is being applied as part of the claims processing. Again, we've got that information from an email from CMS. We anticipate that there will be an additional transmittal that goes out to the carriers in the next several days. But at this time, it's going to be something that is done as an adjustment. So thank you, everyone. What I wanted to do at this point is thank you for your time today. There's no other questions that I've received. So at this time, feel free to hang up, and thank you for your last 15 minutes.